Okay, so I think everyone has had a great lunch. We start with a post-lunch session in Hall B with Office Orthopaedics, Your Everyday Matters. Can I invite on stage the conveners for this, Dr. Chasanal Rathod and Dr. Rajiv Nirawane, and the chairpersons, Dr. Swapnil Keny and Dr. Jaideep Dhamele. Thanks.
Thank you, Mudit. And we have chairperson with us, Dr. Swapnil Keny, and I request him to take over the proceeding for the session.
Thank you very much. We start with this very interesting session on Office Pediatric Orthopedics, and may I now call upon the first speaker, Dr. Rujuta Mehta, to speak about birth trauma, what to watch out for.
Already practicing it. So good afternoon, everyone. In the post-prandial session, I thought it's a bit interesting to warm up with things which come with a great panic in the OPD. Parents are usually terrorized because it's the joy of the child is killed wherein there is a birth trauma. There's a whole list of things that can go wrong actually at birth. And what we'll focus on is a little bit on the femur and a little bit about the humerus. Of course, clavicle is the commonest bone to be fractured. But what I want to stress on the audience is that what tends to be missed is very often the slips at the elbow. Beware that can happen at the shoulder and the knee as well, although they are rare. And the OBPP, which very often gets missed, along with the innocuous looking clavicle and the humerus fractures. So what's the evaluation protocol? Like any other orthopedic injury, the child will always be tender there, but here it will be a tenderness which is noticed while changing diapers or being lifted. There will be a non-usage of the extremity. You will find abnormal mobility in the place. In malunited cases, they may present with a deformity. And sometimes you will find crepitus if you really look hard for the associated trauma. Never forget to take X-rays in two views. Examine the ipsilateral and contralateral joints. Of course, ipsilateral is very important in the same line to look at it because a neonate is not going to be able to tell you where it's hurting, and therefore look hard for associated trauma. Whenever you have multiple long bone fractures like this, you can see here clavicle, tibia, radius ulna, and the femur, to suspect osteogenesis imperfecta. Although it may sometimes just be an indicator of a very, very traumatic delivery if the child was suddenly had to be saved and was suffocating. But all the same, beware that it might be the first pointer of a very severe osteogenesis imperfecta. Most of these injuries heal very well with conservative management and splintage. Strapping is almost given up now. There are many ways to splint it. For fracture clavicle, I generally tend to prefer to tell them just to swaddle the child tightly on the upper body and no need to give any complex bandages, but there are beautiful Wilpue slings which are devised by some of our friends sitting in the audience. And basically the aim of this treatment is to just give pain relief and prevent displacement and maintain the alignment. Neonates have 3 times more regeneration potential than adults. So all you do is restore anatomy and align it well, it will heal very, very well. Occasionally you get deformities, but majority of them have good prognosis. And of course you need to assure the parents. The treatment options for this common fracture are known to most of us, but I think what is not really known is that nowadays there's a very simplified treatment. And why is this? We use the Pavlik harness, which is basically meant for DDH. It's an extended use of the same. It's because you have very good, thick, stable periosteum in neonates. All you need to do is neutralize the force of the iliopsoas, align the distal fragment with the flexed proximal fragment. As you can see here, this just needs to be aligned up. And in 3-4 times, you have profuse callus. If in rare cases you see that the shortening is likely to be more than 2 centimeters or angulation is really above 30 degrees, sometimes you can use a spica. But there are enough papers which show now that the gallows traction, which was actually taught to us when we were training as residents, is almost given up, and see how comfortable the child is. And you can see very thickly, well-united callus over there. There are multiple papers which show that the remodeling outcome is good, and the treatments of Pavlik harness results are just as comparable to others. That's the end of 1 year. However, once in a while, you may get a case where you have periosteal interposition, like this case with Dr. Alaric had very generously lended to me, where there was a sclerosis despite 1.5 to 2 months of treatment in Pavlik harness. Only in such cases, you need to go ahead with the operative modality, and this had to be fixed, and it was found that there was fibrous tissue interposition. This child went on to do very well later. Sometimes, very rarely, you have a physeal separation of the knee post LSCS. And why does this happen? Because the uterus starts contracting very hard, and if it's not a face presentation or a transverse lie, then it's really a lot of force that is required to extract the baby out. So you can see this here on sonography, although you may miss it very easily on an X-ray. And this had come to me already bandaged like that in a plaster, but you can easily see that there was a clear subluxation. So I took the child under anesthesia, gave a above knee slab in extension to maintain the alignment. And in order that they don't kick it off, I attached a Pavlik harness to it just to maintain it as a stirrup sort of on the pelvic wall. And this is the way it has aligned well. This child has grown up now to be 6 years, and she has done very, very well. The other physeal slip, which very often gets missed, is the distal humerus physeal slip. Just take a minute to look at the types of displacement here, and you will notice that if you keep these few figures in mind, you will never miss a physeal separation, because it's the entire distal humerus which shifts medially along with taking the forearm with it. If you miss it, you end up with horrible cubitus varus deformities like this, and this need to be osteotomized. So the best way to treat them is with a closed reduction, as you can see over here, and beautifully it gets aligned under Siam, and then it goes on to do very well. With a clavicle fracture, with a large baby, it's important to look at the brachial plexus. Of course, most clavicle fractures will come like this. The child is so comfortably sleeping, and you can already see the profuse callus which has developed there. Very rarely you may get a glenohumeral dislocation with the OBPP, which I had to reduce under GA, but this child went on to do well, and then the classic transfers. So we'll stop here, I think, for interest of time, and not look at the other details, brachial plexus policies, because that will require a lecture in itself. We'll just keep on the last slide, and yeah, that's it.
Thank you, ma'am. And questions we'll just take at the end of the session.
So, next speaker, Dr. Tushar Agrawal, sir.
It's always a very tall order to follow Dr. Rujuta. But after the child is born, the child then goes on to become a walking toddler. And then the first thing and the most common thing that you will come across is bored legs. And often what happens is, our friends and colleagues who refer to us बोलते अरे एक ब्लाउंस का केस भेज रहे उधर दिख नहीं रहा है बॉस. So my take was to tell you when to conserve and when not to conserve. So look at this video. These are the kind of patients who will be coming to your OPD. 18 months to 2-year-old child, and the parents are anguished with this kind of gait. And look carefully how you will be examining the patient. So first you cover the distal part of the tibia and look for the offset from thigh to the upper tibia. And if that is in valgus, by and large, this patient is safe to conserve. After that, you look for the thigh to foot axis, and then there is no intorsion here, so there is no problem. A large part of your problems are coming from this excessive anteversion. So eventually the child will remodel out of it. So you can conserve, no problem for this kid. Now this is another kid. This kid is waddling a little more than the previous one. He is less well built than the previous one. So how do we examine? The cover test is not looking as good. There is intorsion. So you will be conserving, but you will be a little more careful. You will call this patient a little more often, but the child will grow out of this problem. So we'll show you how sequentially the kids correct clinically. And this is a wonderful follow-up I have of a patient who has just corrected spontaneously from extreme bored legs. This is Binoti's article. It's very interesting. They had a study done all over the nation, and they found that in Indian patients, any varus after 3 years of age is atypical. And maximal valgus we get at 6 years of age. So lock this information in your brains. This is very important with Indian context. Now what happens? You get bored legs with a child, same age, but waddling much more. So you examine for rachitic rosary, you examine like the way I described in supine and prone position, you look at the femoral bowing, you look for intercondylar distance with patella neutral, right? And you look for the thigh foot axis. But look at the x-rays. So what's happening here? So there is evidence of rickets here. So you will conserve, but here you will investigate. You will do blood tests, you will do x-rays, you will do scanograms. Okay? And once, way back when I had spoken on Genu Varum in WIROC, Alric had asked me, will you do vitamin D in all patients? So now there is evidence of literature which says that whether you see radiological evidence of rickets or not, all patients of bowed legs have vitamin D deficiency, so it's best to document it. So you may want to do it for all. Now this is the case of typical bowed legs, and this is a case of an obese child with bowed legs. So the obese child is just 18 months and 18 kgs. Okay, 18 months is 18 kgs is double his weight. He should be just 7 to 9 kgs in weight. So when you are conserving a obese child with bowed legs at the same age, be very carefully, scare the shit out of the parents so that they are able to control the weight of the child. Okay, so in this patient, they maintain the weight, and as the child kept growing in age, he sort of was growing out of his bowed legs. So obese child, same age, same bowed legs is a big red flag. Conserve, but with very tight follow-up, x-rays, have a pediatric endocrine reference if possible. Now you can have distal tibial varus like this. So these are just regular OPD patients. So these time also you can conserve, but be very careful. Do an abdomen ultrasound, rule out renal issues, rule out cafe au lait spots. Just be more careful. So you can't just conserve carelessly. Now this is the classic case of achondroplasia or a skeletal dysplasia. So in all cases of bowed legs, measure upper segment to lower segment, look for dysmorphic signs. So don't miss out skeletal dysplasia. Now age is a very important criteria. So this patient is 11 years of age. So you can never be waddling when you are 11 years of age. So any form of bowed legs and varus at 11 is not right. Have him evaluated, get his metabolic profile corrected, and all varus should ideally correct to valgus. As you can see, I had this patient when she was 10 months of age, and then I had her when she was 10 years of age and she was in valgus. And we actually had to do a 8 plate to her at 10 years of age. So she started with the physiological bowed legs, went into valgus, and then we corrected her. So points to ponder upon when you are observing: what is the age, what are metabolic issues, weight and endocrine issues, body mass index of the child. Draw the charts: femur versus tibia bowing, proximal versus distal versus diaphyseal bowing, intercondylar distance, torsional issues, scanogram. Now we'll quickly go to operative. So this is a case of O-shaped deformity, not conservable. So tibial osteotomy with 8 plates. This is another O-shaped deformity. This is a case of pre-Blount's. What is pre-Blount's? When the metaphyseal diaphyseal angle is more than 17 degrees. Okay? So at that stage, you see this patient. What did we do? We did a tibial osteotomy, very old patient of mine. Femur 8 plates, she corrected. We have a 14-year follow-up of her. This is at 14 years. So started at 2008, at 2022. You can see the X-ray of bowed legs and the straight X-rays now. Now this is unilateral bowed legs. Again, not conservable. Small age, so femur and tibia 8 plates, growing out of it. This is the video where the child has corrected. Bilateral bowed legs, corrected with plate, external fixator. External fixator is not preferred by patient. And in the more late adolescent patients, notice the distal femoral varus as well. So when you are operating, their techniques are guided growth modulation and osteotomy. Decide what device you want to use. So just remember, all bowed legs are not Blount's, and in fact Blount's is a little less common in Indian context. Thanks a lot.
Very well elucidated, Tushar. We call on the next speaker, Dr. Manoj Padman, to speak on Genu Valgum, when to observe and when to operate.
Good afternoon, everyone. So it's logical to follow varus deformity with valgus deformity. That's how children, as they grow up, the axis changes. So I'm going to talk about when to operate and time permitting a few surgical indications. So the first key thing is you need to distinguish between physiological and pathological. Identify the etiology because there may be reversible causes which can be corrected. Have some understanding about the natural history. Make a decision, conscious decision, when to intervene and what are your options. So this is a very useful curve. Tushar touched upon it. Between 2 to 6 years is when you see valgus. Before that is usually varus. Usually when it starts going beyond that, one is a little concerned. So that's the prototype Genu Valgum monocnees that you see in a 3-year-old. So when I have a patient with valgus deformity, this is my checklist. You know, I want to know whether it's unilateral or bilateral. Bilateral is a lot more reassuring. Is it symmetric? Progressive and non-progressive is a little tricky because all parents will report it's getting worse. And you look at other problems as well. Look at the child as a whole to identify other systemic problems or features of skeletal dysplasia. So that's a 3.5-year-old within the permissible age, but it's a unilateral deformity. So that is definitely a cause for concern. In terms of clinical assessment, some of it overlaps with the previous talk. You look at sequential assessments. Intermalleolar distance, I'll touch upon that. That's something useful for sequential assessment. You need to have a standardized way of doing that. Look at where the deformity is coming from. Associated malalignments are usually torsional anomalies. And do not forget to look at a general stature, the overall growth, and other extraskeletal manifestations. So that's how you would check an intermalleolar distance. But bear in mind how you keep the limb. Changing the rotation of the limb, see, depending on where you keep the patella, the intermalleolar distance can change. So you need to have a consistent way, and ideally it is with the patella pointing up, with the legs just about touching each other, the minimal space in between. That's how you should consistently measure if you're measuring them supine. Some people choose to measure them standing, which is a lot more difficult. Here is a child who is well beyond the physiological age, and that is just to take you through a quick 5-minute check. This is, you observe her gait, it's symmetrical, both sides are affected. And the next set of examination barely takes a couple of minutes. Standing alignment, supine alignment, check the intermalleolar distance. When she sits down at the edge of the bed, the valgus disappears. That indicates that it's coming from the distal femur, torsional profile. That's all that you need to look for the lower limb, specifically for the valgus itself. But you always need to look at proximal joints, joint below, as well as other extraskeletal manifestations. I use radiology very judiciously only when I need to when I'm considering that it's going beyond a physiological range, wherein I'm contemplating intervention or where there is a clear diagnostic dilemma. An asymmetrical valgus in a 3.5-year-old is an indication for me to take an X-ray. Bear in mind, you need to take standardized X-rays because there could be a mismatch. Some of these smaller children are difficult to get standardized views. Here is a case of asymmetrical valgus clearly showing axis deviation. That's another one. You need to make them stand in such a way. Sometimes in severe valgus deformity, the radiographer will squeeze the legs together, making the child rotate, and that would under-measure the valgus deformity. You need to make sure that the legs are just about in, you need to see a sliver of air between the two legs. So when I look at etiology, I need to know, are there things which I can correct? Lots of the time it's idiopathic, which could be already treated rickets. Metabolic diseases which can be corrected, need to be corrected. Look for skeletal dysplasia, and often you see asymmetrical valgus as a sequelae. So this is a hypophosphatemic rickets where you have other skeletal manifestations of deformities. That is obvious skeletal dysplasia, fixed patellar dislocation, presenting almost like a flexion deformity. That's how the child walks. Short stature, you can see proportionate shortening of the upper limb as well. This is an interesting phenomenon. We encounter this in our pediatric practice. Upper tibial metaphyseal fracture, treated conservatively. Nothing wrong with that. Counsel the family about Cosen's phenomenon. Once a fracture is healed, due to a variety of reasons, they go into progressive valgus, which is quite stressful for the parents to see. Often they correct spontaneously. Sometimes you may need to do growth modulation. This is clearly a case of sequelae, neonatal septic arthritis. You can see the lateral condyle and the lateral physeal plate completely destroyed in an 18-month-old child with progressive valgus. So when I look at management itself, these are the things that I have my checklist. I look at the etiology, I optimize metabolic profile, I look at the age because that's important for growth modulation. Associated issues need to be factored in. Look at all these factors before you kind of contemplate intervention. This is an ideal age for a growth modulation, 9-year-old metabolic profile. You can see there is some amount of the epiphysis doesn't look normal shape here. There could be an element of epiphyseal dysplasia. Corrects very well. Sequential X-ray showing complete restoration of axis. Asymmetric valgus, younger age, once this is clearly an underlying metabolic problem, renal disease, that's not going to correct. So you're better off intervening early and restoring the axis. In older children, idiopathic deformities, which may be a sequelae of rickets. If they have bilateral deformities, I prefer to do internal fixation and do them simultaneously. You have options of doing with external fixator, unilateral, if you want. Am I frozen? So one key thing, the conventional teaching is varus is from tibia, valgus is from femur. That's not always the case. Sometimes when you are operating on them, you need to check that whether there's any associated tibial deformity and you may need to intervene. This is a case which had the whole bunch of associated problems, leg length discrepancy, patellar instability with valgus deformity. And so you may need to kind of, change your method in terms of how you want to tackle all those problems. This was a fixator-assisted correction, went on to good realignment, restoring the axis and getting the length back, and that's his clinical photograph. So in conclusion, recognize physiological, do not miss any pathological entities. Simple examination can identify the problem, understand the natural history, decide when you want to image, and consider all the options of management depending on the pathology and the age. Thank you.
Thank you, Manoj sir. So next speaker is Dr. Vikas Basa. He will speak on the growing pain.
Yeah, good afternoon, everybody. Thank you, WIROC, for inviting me. And special thanks to Dr. Chasanal because she helped me in preparing my presentation. So often, children get referred from pediatricians. I think even you also may be seeing children with vague, noxious limb pains. And to your surprise, all your examination is normal, and you label them now as growing pains and treat them symptomatic. So is a growing pain a myth or is it a reality? So today, let's unfold the facts. Do our bones really pain when they grow? The answer is no. So the term growing pain is actually a misnomer. So if you review the literature, in April 2021, the Clinical Effective Group has coined the term idiopathic nocturnal limb pains of childhood, or it is also called episodic childhood musculoskeletal pain. So henceforth, we should be changing the terminology. So children between the age group of 4 to 14 years, typically they present pain at night time. These pains are generalized, and the child cannot pinpoint the exact area of worst pain, where the pain is more. And it is commonly seen in children who are very active in sports. A child never wakes up in the morning with growing pain, nor they complain during the day. It's usually at bedtime. So then why would this pain alarm go off at night? So the children, they're very active. They are with endless supply of energy during the day. So a study from a pediatric endocrinology states that on an average, a child takes at least 7,000 steps in a day. So after a long day, their muscles have been working really hard, and there's a constant pull of the periosteum of the long bones. So if the muscles are fatigued, and if the strain on the tissue is more than it can handle, the nerve endings are triggered and resulting in pain. So then why don't the growing pain occur every night then? It depends on how active the child was during the day. Yes, you guessed it right. So the more active the child during the day, greater the pain. Then now you may be asking me, come on, now every child who is growing out there should suffer from growing pain. So it has to do something with some variations in the anatomy. So it's not seen in every child, but if you carefully examine, they may be having, or maybe the occurrence of some angular deformities in their legs, or they may be having subtle scoliosis, or it is commonly with children having flexible flat foot. And these children have hyperlaxity of the joints, and they're very hyperactive. So what are the other associations? So they have low levels of vitamin D, and children, when they play, they do sweat. And if they're not drinking enough water, what happens is they'll have an electrolyte imbalance, which causes muscle cramps, and that is presented as a growing pain sometimes during the evening or night time. So do we have anything to offer them? I would say the best treatment is reassurance. But having said that, we can't leave them to the time to heal. So the best treatment what we have is a muscle stretching. Mainly the biarticular muscles, the quadriceps, hamstring, calf muscle stretching really helps them. Naproxen, paracetamol works well. A gentle massage improves the blood circulation of the muscles. So this may be the reason why the children, they request the parents to press their legs and gradually they go into sleep. And the vitamin D and calcium supplements, and educating them to well hydrate, and of course the reassurance that they're going to heal soon works. Beware of the mimics. Every pain which occurs at night is not the growing pain. So let's discuss and differentiate the growing pain from some red flags. If any pain which is constant and persistent, then it's not a growing pain. That should raise the alarm. If the pain is restricted only to one limb or to one side of the body, that means you're not dealing with a growing pain. In growing pains, the child usually complains of pain in the anterior thigh, shin of tibia, or calf muscle, but it is never around the joints. And it is at night time. And if the pains are associated with the clinical signs of local or systemic inflammation, and if the blood investigation showing raised ESR, CRP, or LDH, that means you're dealing with infection or some tumors. So beware, investigate them properly. And please remember, growing pains never limit the activity of the child. But whereas if it is beyond growing pain, if the child is not playing because of these pains, then you should suspect and investigate further and treat them accordingly. So there are few conditions which mimic like growing pain, but I've listed only few. Obviously the osteoما, because here the pain is at night time. The child is pain-free only during the time he gets analgesics, and again the pain reoccurs. In leukemias and lymphomas, also behave like a growing pain. So unless you do the peripheral smear in your lab investigation, you tend to miss them. And the perifocal facial edemas also behave like a growing pains, like our multiple bone marrow edema syndromes. The fibrous dysplasia and Langerhans cell histiocytosis are among others. So this growing pains is very much reality. It occurs in 37% of the children between the age group of 4 to 14 years. Muscle stretching is the best treatment what we have. And beware of the mimics and treat them accordingly and let the smile continue. Thank you so much.
Thank you, Dr. Vikas. We call on the next speaker, Dr. Chintan Doshi, to speak on intoeing. Can it become normal?
Hello everyone. Thank you WIROC for giving me opportunity to present this topic. So I'm here to present on intoeing in children. It is also called as pigeon-toed child. And we'll go through a case as it is office orthopedics. I'll get this child into your clinic. And we see him walking into the clinic. We see this child clearly walks with an into gait, more on the left very clearly. So now we identify where is the problem. Is it in the feet? Is it in the tibia? femur, or it is just a normal gait issue, which is an immature gait and will get better. So to look at this, the second video is a slow motion video. We see as the child is suspending his foot, the foot is absolutely straight. As soon as it starts to land on the ground, it turns into with the patella facing inwards. So this child will help us in our examination in the further part of the talk. So what is intoeing? There are torsional anomalies in children which we see very commonly. So normal is 5 to 10 degrees of external rotation that all of us have. Into and out toe are away from this normal. So into is any deformity when the child is walking with the toes facing inwards, and out toe is more than 15 to 20 degrees of external rotation is the pathological outtoeing in a child. So what are the causes of intoeing? Most important cause, in infant it is metatarsus adductus, in toddlers it is internal tibial torsion, and from the walking age to about 10 years it's about femoral anteversion. So metatarsus adductus is a medial deviation of forefoot with normal alignment of the hind foot. It occurs in 1:1500 births and 1:20 children. A normal association occurs more commonly in males. In twins, because of the fetal overcrowding and position of the foot inside the womb. It is a benign condition. 90% of them resolve spontaneously by 4 years of age. Remaining 5 to 10% will resolve later by footwear, bracing, and walking methods. Coming to this kid again, this is the kid that we saw walking in the first slide. He has typical W sitting. So W sitting and increased femoral anteversion are related. It occurs commonest in children between 3 to 8 years of age. It occurs more commonly in girls than boys, and it gradually improves as the child grows. So as soon as I told this child to sit in my clinic, the most comfortable position he was able to sit was in W, the first photo that we see. I told him to sit in cross leg. He is unable to do it. He is just able to cross his leg but unable to get the knees parallel to the bed. So why is this happening? Let's look at the clinical examination. So when we look at the torsional profile, we look for the rotations in the limb. So at the hip, the rotations here in prone position with hip in extension, there is internal rotation of 90 degrees and external rotation only possible over 20. He cannot get beyond this of external rotation. When hip is flexed, again the internal rotation is about 90. External rotation, no matter how much ever I tried, it was 25. Beyond that, the child was unable to do. So there is a block to external rotation. Now why is this happening? It is happening because the femur is excessively anteverted. What is happening is that when the newborn is born, the femur is in about anteversion of 45 degrees. As the child grows, by about 4 to 6 years of age, it becomes about 25 to 30 degrees. And by adulthood, it is 15 degrees of femoral anteversion that all of us know. So more than 95% of these kids will need no surgery or no treatment except for some exercises, cross-leg sitting and everything. 5% of these who don't improve beyond a certain age might need correction if it is excessive. So intoeing walking prognosis, as I already explained, the child will grow out of intoeing. It will reduce with growth and maturity. The leg will untwist naturally. The feet first between 3 to 5 years of age. Then the tibia also corrects between that age. And femur usually corrects by about 7 to 8 years, depending on how severe it is. There is something called as miserable malalignment syndrome, in which there is excessive femoral anteversion along with external tibial torsion. Now, this is supposed to be looked at whenever we examine any child with a torsional problem. May it be intoeing, may it be outtoeing, or may it be a completely straight walking limb. Because in this, the feet always face forwards. So when the child is walking, you will see there is no deformity. The feet is always straight. The foot progression angle is maintained to 10 to 15 degrees. But the knee is facing inwards. So what is happening? There is constant abnormal loading on patella, which causes long-standing anterior knee pain. And in this, if it is bothering the child, it is always recommended to do a surgery because it will further lead to patellofemoral arthritis. So surgery when is needed? As we already saw in the prognosis, 90 to 95% of them will recover. Only about 5 to 10% of them may require a surgery. These are the cases which may have neuromuscular conditions, may have skeletal dysplasia, in which the torsion is excessive, not beyond the normal. Surgery is recommended to be done after about 8 to 10 years of age because most of the femoral anteversion gets corrected by 8 years. Derotational osteotomy can be done at tibia and femur both. Usually we prefer at diaphyso-metaphyseal junction. It is basically a cosmetic surgery, but it prevents further patellofemoral arthritis and other arthritis of the joint. There is high recurrence if done early and in low deformities. Thank you.
Thank you, Chintan. Now I will call next speaker, Dr. Maulin Shah sir, for his talk on transient synovitis of the hip.
So thank you very much, organizers, for this opportunity. Now, transient synovitis is a self-limiting joint inflammation that we all know and is the most common differential diagnosis of septic arthritis hip in children. The problem is in early stage of the disease, both these conditions share same clinical, pathological and radiological findings. And it is very important to differentiate because if we miss septic arthritis, the outcome is very devastating, and the treatment of both these two conditions are entirely different. Now, since Chasanal called me that you have to talk on this, the same day, 2 boys came in my clinic, and I followed them. Let's talk about tale of these two boys. So both of them are around 8 to 9 years old. Boy 1 is quite irritable, and you can see when you adduct the limb that there is apparent lengthening, and he was not able to walk, but when I asked, can you walk, he took a few steps and he was limping terribly. And these symptoms were there for 5 days, and both these kids had episode of 101 degree of temperature, and both were refusing to bear weight. Let's look at the boy 2, and he was also quite irritable, keeping the leg in external rotation and flexion attitude, and very irritable and crying when we tried in passive motion. So we went on to do the laboratory workup, and you can see the laboratory workup came equivocal. The total count were in the range of 12,500, 13,500 in the other child. Differentials were almost normal. ESR was raised in both of them, and C-reactive protein was 22 in boy 1 and 28 in boy 2. So in blood investigations were also kind of equivocal. We got an ultrasound, and you can see that there was moderate hip effusion in both the child, and there was no change in the density of the fluid. So based on all this information, we were confused whether we are dealing with both septic hip or both of them are transient synovitis or what is it. So it's confusing. We know that the Coker's criteria is very popular. This criteria is laid in 1999, where they have devised 4 algorithm criteria: the history of temperature more than 101, inability of child to bear weight, total count of more than 12,000, and ESR more than 40 millimeter at hour. If you have all these 4 factors, then there is 99.6% chance of having septic arthritis. Now, we know that ESR is not that sensitive criteria, so Bruce et al., they added C-reactive protein, and when C-reactive protein is more than 20 milligram, they found that C-reactive protein helps making this diagnosis more easier. The problem of this all algorithm is, though, we know that if all the factors are present, we are very clear in diagnosis, but many of times we have only 2 factors and all. And when these were applied in a retrospective study, it was performing well, but performance of the algorithm reduced when it is applied prospectively. And CRP was found to be a better predictor than ESR. But CRP was more reliable to exclude septic arthritis, meaning that if CRP is normal, then you might more confidently say this is not septic arthritis, this is probably transient synovitis. But a positive CRP does not mean that it is a pure septic arthritis. It can be also present in transient synovitis. So clinical acumen of surgeons still is paramount in these borderline cases. What is the role of radiology? X-ray is usually normal, and ultrasound shows similar picture in early phase of both the disease. It is very important to know that neither quantity nor quality of the joint fluid can guide us or differentiate between transient synovitis or septic arthritis. We have seen many reports of turbulent fluid and it turned out to be a transient synovitis. More focus is now towards getting an MRI in confusing cases, and with this recent studies, what we have found that when there is associated bone marrow edema and soft tissue involvement, there is more likelihood of septic arthritis. Although these changes were seen more in patients who had symptoms more than 3 to 4 days. There were a lot of patients with normal bone marrow when the MRI was done after only 2 days of symptoms. Another finding which came out of this study, this contralateral joint effusion is present, then there is likelihood of transient synovitis. So we are now trying to get MRIs, but the role of MRI is also questionable in early disease. Well, then what is the future? Will we remain confused all the time? Now this recent paper shows that a pilot study has been done where they have checked the cytokines, that TGF alpha and other interleukins they have checked, and they found that this 4 cytokine panel has 91% of sensitivity and specificity. This is not available in India at the moment, but maybe in coming years we might get some test which can distinctly differentiate between these two conditions. So what we follow, most of us, that when an acutely irritable hip comes, we do some basic investigations like WBC, CRP or ultrasound. If the reports are normal, then we very confidently treat it as a transient synovitis. But they are fairly increased, then you have to consider septic arthritis and consider arthrotomy. The problem or confusion comes where there are marginal increase in their symptoms. Then we follow these patients up for 2-3 days, giving traction if possible and NSAIDs, and see the response. Those patients or fever subsides, there is no more episode and symptoms improve, we can watch them. But there where the fever and symptoms worsen, we might get an MRI and confirm the diagnosis and proceed for treatment. Do not start oral antibiotics when you are confused whether it is septic arthritis or transient synovitis, because that will make the picture more confusing. Just give oral anti-inflammatories. So we followed the same protocol for both these kids, and the child 1 improved with oral anti-inflammatory and traction. This is 2 weeks follow-up, so he did not require any surgery. While after giving naproxen for 2 days, this boy 2 kept on worsening. He could not walk, his pain was persistent, and he underwent arthrotomy and drainage of the hip. And at 2 weeks' time, this boy also started walking well. So that's how we apply this criteria in our clinical practice. Thank you very much.
Thanks, Dr. Maulin. I hand over the proceedings to the two conveners, Dr. Chasanal and Dr. Rajiv, to take the question and answers and also to summarize the session.
We can have 1 or 2 questions.
Don't mind, I would want to ask Maulin. Are you telling the audience that MRI is a must to differentiate between transient synovitis and septic arthritis?
So MRI is not must, and most of the time when a child is able to walk and the blood counts are not very high, then you can treat them as transient synovitis. MRI is required when the illness is prolonged and when they are equivocal clinical picture. Now remember that MRI will be differentiating between these two when the disease illness is more than 3-4 days. If the symptoms have started for only 2-3 days, then MRI might only show the effusion, which can also be present in transient synovitis. So MRI is not must for all the cases, just for those with elongated illness.
So I just would want to add on to that transient synovitis is essentially a clinical diagnosis. Your child would be younger, there will be hardly any fever, and the range will get restored fast. If the range persistently remains affected in an older child, and that's where you want to differentiate, if there's some pre-setting of immunocompromise where you need to do investigate, only then should you go ahead with an MRI.
Yeah, so one question.
So,
Can you come to the...
probably the question is that if you have effusion, do we aspirate all the time? Yeah. So for the routine, again I'll reiterate that if a child is not able to bear weight and follow all these 4 criteria, then that's a diagnosis of septic arthritis. Then the high grade fever, high CRP, that is matching. There are some equivocal cases, but I prefer to give anti-inflammatory and see for 2-3 days and how it responds. As ma'am said, most of the patients with inflammatory, they respond very well to anti-inflammatories. Do we, any one of you, do joint aspiration to make diagnosis? No, we don't do it routinely.
Last question.
So before you do arthrotomy to Dr. Maulin Shah, do you do blood culture? And second question, what is the approach for arthrotomy? Third would be, do you send whatever the fluid for person culture sensitivity?
Yeah, so the question 1,
Do you do
blood culture. Yeah, for an established case of septic arthritis and associated osteoarthritis, we do blood culture. That's one. Anterior approach, we do not do arthrotomy to posterior approach because that might lead to a vessel insult for the femoral head. So anterior approach. And the third one, third question.
Whatever the fluid you drained out, do you send it for?
Yes, of course. We send for blood cultures. The material we send for the culture, and if there's granulation tissue, then we send for biopsy as well.
Okay, so thank you so much, and we have the next session.